Thank you. So it's wonderful to have the opportunity to speak to everybody this evening. My name's Llewellyn Walker. I'm a consultant clinical pharmacologist and general physician from the Royal Liverpool University Hospital. So I'm a hospital doctor. I am also a clinical trialist, so I'm an associate director of our NIHR clinical research facility, which means I'm responsible for the testing of new medicines as they go into humans for the first time. So the very beginning of the drug development pathway, when we move into the kind of safety arena of testing drugs in humans for the first time, and that tends to be done in young, fit, healthy individuals. But in my clinical work, a large part of my clinical practice is that I'm referred patients who have multiple different medical conditions, something we call multimorbidity, and who take many different medicines, some that are symptomatic treatments and some that are preventative. They prevent their diseases from progressing or prevent the complications. And the taking of multiple medicines, or usually more than 4 or 5, we call polypharmacy. Next slide, please. So I wanted to talk to you this evening about a concept that we call problematic polypharmacy, or potentially problematic polypharmacy, because not all polypharmacy is, you know, there are a lot of headlines about the dangers of polypharmacy and how, as we get older, that, you know, there's a lots of risks of being on multiple pills, and we hear that a lot. And I just wanted to stress that there, you know, a lot of polypharmacy is entirely appropriate. It might be completely reasonable for somebody who has 5 different diseases to take 10 different medicines. What's essential is that our medicines are regularly scrutinised by somebody with medicines expertise, because of the way that we process medicines and how that changes over time. And one of the biggest problems that we have that's associated with medicines and with the ageing process is the increasing risk of something we call adverse drug reactions. And there was a study that was done about 20 years ago in looking at hospitalised inpatients, and showed that about 6.5% of all admissions to hospital are caused by or a significant contributor is a prescription medication. So that could be that you take a blood thinning drug like warfarin in order to thin your blood to reduce your risk of having a stroke in later life, but you fall over one day and bang your knee and you have a big bleeding joint, and that would be an adverse drug reaction. It would be an unintended consequence of the medicine that you're on. And there are many, many different examples. So that was 6.5% in all people, but when you restrict that analysis to just people that are older, in an older age group, that goes up to a quarter. So 24% of admissions were, you know, it was caused by a drug in older people. So, and we think that that problem is likely to be much worse. That study was done nearly 20 years ago, and we know now that the average 70-year-old takes 2 additional pills each day compared to just a decade ago. So the amount of polypharmacy that we're seeing, the amount of available medicines is increasing. So therefore that risk might increase. And adverse drug reactions is probably one of the top 5 risks to the health of the elderly, with falls being the commonest cause of injury in older people. So it's a significant problem. And what I wanted to talk to you a little bit about was how getting older increases your risk related to medicine. So it's going to feel a little bit as though we've gone back to school. But if you could, the next slide, please, Harriet. So why it might be a problem. This is a complicated area, but there are 3 main features that I wanted to talk about. The first is to do with your kidneys. So as we get older, our kidneys shrink in size, and the functional units of the kidneys reduce in number. So the nephrons, which is what you can see there, that kind of wiggly filtration system. If you imagine in the kidney that you have a series of sieves, a bit like your kitchen sieve, blood, where when we take a medicine, swallow a tablet, it's absorbed into your bloodstream. That blood is filtered through the kidney, through that, you know, multiple tiny sieves, passed through, and the majority of that will pass out into your urine. And that's how it's eliminated from the body. And I'm making generalizations. There are many medicines that are not eliminated that way, but in the large part, your kidney is the main site of drug elimination. So as you get older, as you can imagine, if your kidneys shrink in size and you reduce the number of sieves that are available to you, the amount of blood that you eliminate per minute is reduced, which means that drug will potentially linger at a higher concentration in your blood for longer. And that's really important for some medicines that in particular have what we call a narrow therapeutic index, which means that you only need a very small increase in the concentration of the drug in the blood to have a big increase in terms of the toxic side effects that you might experience. So a commonly prescribed example of that would be something like digoxin, which is a medicine that people might take who maybe have heart failure or who have a disturbed heart rhythm, and they use that as rate and rhythm control. So it's not an uncommonly prescribed drug. Other examples include something like gentamicin, a relatively commonly prescribed antibiotic, which if in toxic levels develop can cause significant kidney injury and is a big cause of kidney injury in the UK. So there are challenges there. Sorry, if you just click to the next image, thank you. The second kind of major concerning problem that happens as we get older is that our liver begins to shrink, and also the amount of blood flow to the liver reduces. And this is a slightly complicated one, and there are exceptions to all rules, some slight generalizations, but the majority of medicines that we take, tablet medicines that are swallowed and absorbed into the bloodstream through the gut, are taken up and metabolized or changed in the liver by the enzymes that are in the liver. And we call that process, that first entry into the liver, something called first pass metabolism. And you can see on the little diagram there that if you take the tablet, it passes into the lumen of your GI tract and is absorbed into the bloodstream, passes in this big vessel, the hepatic portal vein, which takes the blood to the liver. And it can therefore be changed in the liver, and it's only what remains after this metabolism, this changing of the drug, that's actually free drug able to exert its effects on the body. So, if you imagine what happens as your liver shrinks, as your ability to change drug changes, and you're not able to metabolize as much, then again, the same situation occurs. You have more of the free active drug in your bloodstream. And good examples of that include morphine is extensive, what we call extensive first pass metabolism. So if you take any tablets that have a derivative of morphine in, or any of those, then as we get older, you become much more sensitive to the effects of opiates, and it can make you, increasingly drowsy. I think a good timely example at the moment is a medicine is remdesivir, the antiviral treatment that we're seeing used in severe COVID-19. Remdesivir is almost entirely metabolized in the first pass. It's why it has to be given as an intravenous drip. So you don't take remdesivir as a tablet. There's a line that's passed into a blood vessel and you take it that way. And that's to avoid first pass metabolism, because otherwise it would be entirely metabolized and changed. And the purpose of that is you've got to change the drug in order to get it to be water loving, hydrophilic, and pass out in the urine. So that's another reason why we become much more sensitive to certain groups of classes of drugs as we age. And if we can just click again. And the last point that I wanted to make was just about how our musculature changes for certain medicines. So as we get older, unfortunately, it doesn't matter, good to spend a lot of time in the gym, but unfortunately, aging muscle, we do get increased fat stranding, and so there is a replacement of lean muscle mass with fat, and there's an increase in our total body water. And there's a sort of complicated explanation for that, but there's a lot of drugs that will linger in the body for much longer as a consequence of that, or increase what they call the volume of distribution, so remaining within the fat tissue for much longer than anticipated. So the reason that I labour this point is that I am used to recruiting patients into clinical trials to test new medicines, and they're usually young, fit, in the most part, young, fit, healthy men that we do the safety part of drug testing on. We look at what is and predict the dose of a new medicine based on that data. But as you can see from these slides, as we get older, the way that our bodies process drugs and handle drugs changes quite significantly. So what was perhaps in a young, fit, healthy man the right dose, as we get older, maybe that we need a dose reduction, or certainly one of the things that we need to consider is at what point do we need to stop thinking about using a preventative medicine, and what point is the potential harm from the medicine outweighing any benefit that we might get. Next slide, please. And the last point that I wanted to talk about was the concept around the appropriateness of clinical trials and clinical guidelines. And I just wanted to preface this by saying, I'm a big advocate of medicines. Obviously, I'd be out of a job if I wasn't. I'm a passionate advocate for the safe and effective use of medicines, and I certainly don't think that We shouldn't be using medicines as we're getting older. But what I would say is it's essential that our medicines are regularly and rigorously reviewed by somebody with medicines expertise. That starting a medicine at the age of 60, that's a dramatically different prospect to if you then take that medicine for 20 years, how not only your physiology changes, but also how your thoughts and feelings and preferences about your medicines might change. And that's particularly relevant to medicines that have quite profound effects on our lifestyle. If we think about water tablets, diuretics that are quite commonly used for blood pressure or heart failure, they can have a profound impact on somebody's quality of life, because if you're having to go to the toilet every 20 minutes, it can be really that can be really challenging and upsetting for people. And I've had patients who have stopped going out entirely because they're anchored to the house because of taking water tablets. And it's for lots of people, their preferences change over time. So there was a study, a systematic review that was published that looked at 283 randomized controlled trials, the kind of gold standard of trials between the periods of 1994 and 2006. And these were all trials that were published in high impact journals. And the purpose of the systematic review was to look at what were the inclusion criteria and exclusion criteria for these trials. What were the things that allowed you to be a participant in the trial, and what were the things that meant that you were not a suitable candidate? And this was all for medicines for individual disease conditions. And the authors found 38.5% of patients were excluded because they were considered to be too old. And that shows you that across the board in different disease areas, that age upper limit can vary from 65 to 75. And yet we have many, the predicted age for many people is over 80. The lifespan for many people is over 80, but often older people are excluded from clinical trials. 81.3% were excluded because of the occurrence of another common medical condition. So what quite often we will do is, if we want to develop a new drug for diabetes, for example, we might try to include just people with diabetes and exclude people who have other conditions, because you really want to prove that your medicine is safe and effective in the disease that you're interested in. But we all know that real life is much more complicated than that, and that most people who have diabetes will quite often also have high blood pressure and high cholesterol. They may well in 10 years' time have heart disease. That real people have many other kind of mitigating factors above and beyond that individual disease of interest. And half of them were excluded because of commonly prescribed medications. And again, we know that lots of people take multiple medications. So sometimes our trial criteria are a bit too strict to really be truly representative of real life. So in the States, they did a study in heart failure of about 20,000 people who were discharged from an acute care hospital, and found that less than a quarter of them met the inclusion criteria for the landmark heart failure trials that govern the treatments that we now prescribe. And that doesn't mean that those people won't get any benefit. The people that were excluded, it doesn't mean that they wouldn't get any benefit, but I think it's really important to acknowledge that they're not, by not being included, it allows you to have that conversation with somebody to say, well, you have other conditions, this evidence base may not be applicable to you. And certainly for us to campaign to have trials that are more representative and start thinking about how do we include people with other commonly occurring diseases. And the same was true in New Zealand. There was a big study looking at COPD, or long-term bronchitis and emphysema, and found that the majority of community-dwelling people with that respiratory condition would not have met the inclusion criteria for the trials that dictate their guidelines. And a similar thing was true for the asthma guidelines. And in Scotland, they did a big clinical database study looking at type 2 diabetes, and only half of those patients, again, would have been eligible for the trials. So, the kind of summary statement for that is not that the guidelines aren't any good, because they are. They're the best evidence that we have for the treatments to be effective, and that's what we should be guided by. But there is a real need to consider that evidence base in light of the person that's sitting in front of us, that may well be much more complicated than anybody that was ever included in the trials, and to have that open, honest, frank conversation in view of that, and in view of the changing physiology, so that we can really start to have proper engagement and discussions with people about the medicines that they're taking, to make sure that we get that right. And I think that's what clinical pharmacists and clinical pharmacologists like myself really have to offer about when it comes to medicines in older people. I think the last slide. So it was just to say, in summary, that I think medicines optimization is essential, and that might well include dose reduction and indeed stopping some medicines at that point. You know, that we talked about the idea of a tipping point, that maybe there comes a point in our life where the taking of multiple medicines actually might risk more harm than it does good, and that evidence base is a little uncertain. And what we need to be able to make those kinds of decisions and have those kinds of conversations with better information is bringing together data from lots of different sources, not just people's GP prescribing record, but their hospital attendances, their health and social care data, where they live, the access that they have to healthcare, lots of different things, and not just take a snapshot in time, but to take a look, a trajectory over time and how things have changed with their prescribing. And also to think about support in special populations, and in particular in children. An increasing number of children are taking multiple medications, so there is a real life course consideration that we need to have. And that was all I wanted to say, really. So thank you very much for the opportunity to talk to everybody, and happy to take some questions later.